So basically, we were, like in the previous session, we were just showing new devices, occluders. Now we will show you new tools, from sheaths to, more, software things. And well, Ole.
Yeah, the first
You're
speaker.
the first speaker.
The first speaker is Ole. And Ole, you will give us some insights in 3D intracardiac echo and the European experience at 1 year.
All right, good. Yes, indeed, about the Philips 3D eyes, which we have now since when? Since July, wasn't it? July last year, I think, since almost a year in Europe. And there's some people here in the room who also have experience with it, I know. So first, a little bit more theory. The potential benefits. You have this on the patient level, hospital level, benefit cost discussion. So first on a patient level, I think there's still a little bit in some operators, maybe suspicion that maybe eyes-assisted or eyes-guided LAA closure is maybe less safe as TOE or TEE-guided LAO. But I think in the meantime there is good data on this, that in literature, that it is as safe. This is about procedural success. The other one is about the complication rate. You even see there in pure absolute numbers lower procedural complication rates with eyes than with TE. I would say, of course, it's always difficult to interpret this. This is from the literature. I think you should really look into real practice. It's all coming down on experience. I mean, if you have good experience with it and you build it up in a safe way from in the start, and you do enough of these cases a year, you have enough volume of it, I think you become good at it and you can do it in a safe way, as it is with any other cardiac intervention. And then also, which is maybe even more important, you see here eyes-guided LAO, the outcomes of it. So here you see on the left-hand side, this is outcomes of routine intracardiac echo used to guide LAO occlusion, peri-device leak, minor leaks, major leaks, because that could be the critics from some, that you say, yeah, well, if you use eyes-guided LAO closure, you can get the device in place, but maybe you will end up with much more leaks. I don't think that's supported by the literature, on the contrary. And then on the right-hand side, that's for the Watchman device only, also similar outcomes. Does the surpass eyes LAO data suggest caution? I don't think so. I mean, again, you see here on the left-hand side, the composite of adverse events with eyes was 5.2 versus 4.6. No difference there. Mortality, of course, no difference. Pericardial effusion, not really a difference. And also on the right-hand side, successful LAO implant, complete seal, and general anesthesia use. I'm still surprised to see in 61% of eyes-guided LAO closures that they're using general anesthesia. That's my whole point why I use eyes, is actually to do these cases in complete just local anesthesia. Just a patient where we're talking with and who's completely relevant and awake. That's the whole point of doing eyes-guided LAO closure for us at least. Sorry, I will go further here. Also, this is then again with the specific VeriSight Pro, that's a Philips 3D eyes. There's also there some reports, small reports with small numbers though, but again showing that it's a safe approach to do 3D eyes-guided LAA closure. Also, eliminating general anesthesia in structural heart procedures has of course resulted in patient benefits as such that yeah, you can avoid complications which are maybe related to the general anesthesia. And also here the patient comfort. So you see here esophageal tears, aspiration pneumonia, stomach laceration. I mean, this is maybe really seldom, but on the other hand, with eyes-guided LAA closure, I never have seen any of those in any of these complications. So I think it's an extremely safe approach for us, at least it works really well. And also even just the flexibility, I can plan my cases. Sometimes I can plan an LAA closure on any day, just in the middle of two TAVI procedures. I can take it on top of another cases on my list on another day. So the flexibility I have of planning in my cases, I'm not dependent on anybody else. It's just if I'm there and I have two nurses and I have a fellow, we just do the case. I mean, I'm not dependent on an imager or an anesthesiologist. I mean, this is extremely easy for me to do my scheduling. So on the hospital level, this is then also again focused on the VeriSight Pro 3D eyes. So it was suitable alternative to TE. Here it says in 89.5%. I don't know why they write 100% because in my hands it works in, to be honest, in 100% of patients. And there were 0 peri-procedural adverse events in this series of patients where they used the VeriSight Pro 3D eyes probe. And you see here, that's indeed what I said, the simpler scheduling. So you cut out really a lot of people you need. On the other hand, I have to say, if you go to 3D eyes, there I think I really need an imager again, because it's for me, maybe it's doable, but on the other hand, it becomes too complex. I think the beauty about 3D eyes is that you have the possibility to do MPR imaging, proper sizing, and that's not something I can do. Maybe I can do, but I don't do. I don't do it at the same time while I have catheters, delivery catheters in my hand. So I typically have an imager again, then who controls the console. I control the eyes probe, and so in these cases with 3D eyes, I have an imager on board again. Also, Everett, that's about how quickly you can change your patients in the cath lab. For me, at least in a university hospital, I mean, changing a patient with general anesthesia, that costs me tremendous amount of time. I mean, it costs me more than an hour 15 in between patients, whereas if it's in local anesthesia, typically you can reduce this to half an hour, 35 minutes. So I lose a lot of time with general anesthesia, to be honest. But that's maybe very site-specific, of course. This slide I showed before. And also, if you have to anticipate, that's maybe more for the American market, but hopefully also for the European market, if there's increasing numbers of LAA closures, then you have to be able to do more cases on a shorter time span. For example, I'm limited to maximally 1 day a week or 1 day every 2 weeks where I can plan LAA closures. Of course, I want to squeeze in as many cases as possible on that one single day. And then cost-benefit, I don't want to go into that discussion because that's very different for the European context. Many of you will argue that, yeah, okay, but the anesthesiologist is in the hospital anyway, or the imager is in the hospital anyway, so that's not a cost, whereas my eyes probe cost me maybe 4,000 euros. Well, I mean, in the US context, it's different. Even in the Danish context, it's different. My heart center has to pay to get an anesthesiologist in my cath lab. So for my heart center, it's indeed a cost reduction if I don't need anesthesia or I don't need an imager. So we can cut in personnel costs. So for me, in the Danish or US context, it's of course attractive to have eyes and less personnel costs. So this is kind of a summarizing slide here. As you see, I think there's a lot of potential benefits on the use of eyes and specific also 3D eyes. The great benefit about 3D eyes for me is really that 2D eyes is purely a tool to guide me, to do a proper transseptal puncture, to do a proper execution of my LAA procedure, closure procedure, as planned on typically CT. So I have a full 3D imaging up front. Whether it's CT or 3D TOE, I don't know, but you need proper 3D pre-planning if you're going to use 2D eyes only under the procedure. I do use 3D eyes. The benefit of it is that in a way you could potentially skip, I don't at this moment, but you could potentially skip your 3D planning up front. And what is definitely true is that you can do a proper and reliable sizing of your LAA under the procedure. With 2D eyes, in a way, I don't even measure anything. The sizing is not accurate, but with a 3D eyes probe, I want to show you that in the case here. So this is a case, I don't know, a couple of weeks ago we did. So it's not a tremendously difficult anatomy. It's just some kind of classical chicken wing with good, nice depth. Okay. So here you see the classical CT sizing. Yeah, you see already, so this case was planned now for Watchman Flex. What we typically do is, we have some idea about the anatomical ostium, but of course, as most of you know, if you do sizing for a Watchman Flex, you don't want to measure the anatomical ostium, you want to measure the ostium, or so-called where your crown, your ostium of your Watchman Flex is going to be. Yes, so that's typically a couple of millimeters deeper in. So keep an eye on that. That's the size there is around 27 by 22 millimeter. Yes, that would be 27 by 22 and a perimeter-derived mean of around 25. So having this, I will probably go for a 31 millimeter device. That's how I do it at least. So I go for my not anatomical ostium, my Watchman flex ostium, measure it. I have a perimeter-derived mean diameter of 25. I want 20% compression, so I end up with a 31 device. The 31 device is also larger than the maximum diameter, which is 27.2. So no doubt, to be honest. So this is then the optimal implant view. In this particular case, it's an REO 30, cranial 4, so that's great to know. And then this is in the case here. So me and my colleague there's a fellow on the background taking some pictures, it seems. And then that's not the usual setup. Typically, it's a fellow who executes the procedure, but this was a recorded case, so I was executing it myself. And then you see here, this is the eyes. We have a good tenting, and then we come, this is with the Versa Cross, which seems like we're playing there even with some CT fusion imaging, which we don't do standard at all. That's why there's also a pigtail in that aorta too, because we have to use that in the Siemens to do the calibration well. So here the Versa Cross comes out, Versa Cross wire. I don't think this was the Versa Cross Connect, because or maybe it is, I don't think so. This is the regular Versa Cross. And then here is the injection. We clearly miss some counterclocks still. It confirms indeed this is in the REO 30 cranial 5 or 8. Then we get the eyes imaging. Let me show here. So this is the 3D eyes, Philips VeriSight Pro 3D eyes. So we're gonna put the sector, and that's very familiar for those doing 3D TOE, I think. So it's exactly the same. You can do MPR there. So there the box is put on, and then let's take a minute to have a look on the sizing. You see there also the pigtail catheter going into the appendage. In a way, I know from my CT that which device I'm going to use, but this was also more to demonstrate. So here he can put his lines, as you see here on the top two windows. He has to put his lines correct where we think we have to agree on where I want to implant my device, and then he can put these lines there to measure where the crown of that Watchman flex, if you still call it crown, I don't know, but he puts it at the region where he wants to be. And then you see, of course, then on the left lower panel, you will see indeed at that plane, you see a cut, a slice through the appendage. So it's maybe not totally perfect. I'm not totally 100% perfect, happy, I think, about the left upper one. I think it should have been counterclocked a tiny bit more. But otherwise, I think this is pretty fine. So you see, again, we don't go for the anatomical ostium, but really trying to envision where the device should land and where I think as an implanter can... So you have to communicate, me and the imager, we communicate, and we have to agree upon where we want to implant the device. And then here, the sizing. So, and you see there on the right top corner, so he measures there 27 by 21, yes? So to remember, yes, so this was my CT planning. I had 27 by 22, so it's extremely similar. Yes, so that confirms that the 3D eyes imaging sizing is extremely accurate. It's exactly the same as I have on CT. I think that's probably the same if you do 3D TE imaging and sizing, but it shows that the value of multiplane reconstruction sizing of LA, you can really match, and it confirms actually my device size for the 31. Yes. So then we move on. Let's see here. That's maybe the more boring part, but yes. So ring to ring. Make the click. This was some educational case we had to record, so I think we talk a little bit more under the procedure. Yes. And even also if you do eyes-guided LAAC closure, I can tell you, I mean, this case is now cut in parts, but from puncture to closure, these cases nowadays typically take around, honestly, like 30 minutes max, I would say. They don't take longer, even with that one additional access and having the eyes. Also, the crossing of the ice probe to the left atrium, that's clearly in the beginning, the hardest part. The biggest learning curve is there. But if you've done a couple of hundreds of these cases, it goes actually really, really smooth as well, I would say.
Ole, while you're showing the case, can we get a question? Because we're like short of time.
Please do. I think it
So
takes
Xavi,
just
you
1 minute.
had a question or a comment?
Just thank you for the presentation, Ole. We are one of the few operators, we're doing eyes with most of our cases, but we need to acknowledge some of the limitations. And let's say that probably with 2D eyes, the quality of color, it's not good at all. So I think that most
The
of
quality of
Doppler color.
color for checking for leaks, you mean?
Yeah, that's it. So I think that probably the success relies more on the CT pre-qualification than the procedure itself. What's your opinion on that?
Yeah, I don't know. I mean, to be honest, if I compare my closure rates in my center with other published, it's far better, to be honest. So maybe it's just based on the CT, I would say. And I mean, how often do you really reposition because you see you have tremendous leaks? I mean, you see it also then with the contrast injection, I would say. So I'm not 100% sure if that's Doppler, color Doppler is really, for me, it's not a determinative factor to reposition devices very often, I would say.
Honestly, if we see a leak, we see it on CT post-procedure at 1 to 2 months.
Yeah,
So.
yeah, exactly. Yeah.
Any other question while, you know, like the watchman's getting...
Yeah, we're
implant?
explaining. Yeah.
I mean, Ole, for me, I'm from Germany, and I'm always impressed if I see that far over 90% of the TE-guided procedures are done under general anesthesia. So obviously the Germans are tougher because we usually do deep sedation and no general anesthesia.
No.
Laura, maybe you can add on that.
Well, I really like the case because it's highlighting how nice it is to can guide with 3D. That is the thing that we already do with the TOE. And on the other hand, I think it's not totally like true the comparisons that you show at the beginning, because it's always compare the eyes with the standard T guiding. That also for some centers they put a 3D probe, but it's not 3D guiding. And also you always talk about general anesthesia, but now with the mini probes, we are doing also with the patient totally awake. It's just anxiolysis. They talk when you finish. And we avoid to have general anesthesia there. We also don't have any arterial access. I saw there a pigtail. And I think the turnover...
Yeah, that's not a need. That's because of we were playing with the fusion imaging there. But
and the turnover of the room, it's the same as if you are using eyes and without less intervention. And regarding the cost, if you avoid general anesthesia, if you really spend less money using eyes, probably I need just to move to Denmark to work, because, you know, every eyes is quite expensive. You know, you can
but again, this is not a plea to do. Just, I mean, every setting is different. Spain is different than Denmark, indeed, or US. So, I mean, this is just one of the possibilities. It's just, I don't say this is the way to go.
No, but the only thing is that it's always the comparisons made with the standard.
No, but indeed, I think we have to step away from these comparisons. I mean, you have to deal with the setting you have to work in, but this is one of the options. I mean, for us, eyes works definitely the best, and then 3D eyes, the benefit it gives the 3D eyes is really that you can do a proper sizing. That's actually what I just wanted to show, that if you see the CT sizing on the 3D sizing on the 3D eyes probe is exactly giving the same.
Yeah, and also the imaging, it's super good.
You see here also, it's extremely good quality, in fact. You see there, now we're putting also the color on it. We even make, I don't think if you have the time, but it will show some 3D reconstructed images even. You see how much protrusion there is from the shoulder. There's a little bit of shoulder, but you can really precisely look at this. So, I mean, it really definitely has added value, I think. Yeah.
Ole, who is managing the catheter in your hospital? Is
the ice probe?
Cardiology, the ice probe?
Most of the time it's me. I'm doing the ice probe, and then the imager is busy with the console. Yes, but I control the ice probe typically myself.
Yeah. Can I add something as well? So I'm also an imager. I'm doing transvaginal echocardiography with the team, and I think that, so this is what I wanted to ask, if it's you who's manipulating the ice catheter or is your imager, because sometimes imagers will be very exigent with the cut planes. They want to have a stable cut plane. They want to have accurate measurements and so on. So I think it also depends, of course, on who's handling the catheter. And I think that your images are actually wonderful. They're very stable. They're very clear.
But typically, during an LAAC closure case or even during tricuspid tear or so, I don't fiddle a lot around with that catheter. I put that catheter somewhere in a good position and I leave it. I leave it laying on the table. So it's not that I'm very nervous walking or running around with that catheter. That's a bad thing, I think, indeed. Typically, I find a proper position, and that's where you work from. Yes,
okay, so it's quite stable actually, because I've never used this, so I have no idea. So it's quite stable. You put it in the left upper pulmonary vein, you leave it there, you have the 3D image, and then your imager does all the measurements, and it's stable, right?
Yeah. Yes.
Okay, thank you.
Most of the time it's like that. Yeah.
So probably, I think that we need just to move on. I don't know if you have like a final slide of conclusion or you want to say something.
No, that's fine. You also see here, this is the final result, so it's a perfect occlusion also, so I think the sizing was right. So I think it was just a demonstration of how you can work with eyes, with 3D eyes. The 3D eyes, for example, I use it for sure in patients who cannot have CT due to renal function typically. Then I think this is a great add-on for me in my lab. But indeed, you have to see cost-benefit what you use. Yeah.
And maybe a final word, but Marek maybe come already to the podium. A final word, Ole, would you use ICE without pre-planning at the moment? Would you suggest it?
Yes, so if I wouldn't have pre-planning, then 3D ICE, yes, I've done cases like that. Yes, so I've done recently, the last 3-4 months, 2-3 cases which couldn't have a CT, and then no pre-planning, just go into the case 3D ICE. With 2D ICE, I would never do that, to be honest. Yeah.
Thanks, Ole. Excellent presentation and excellent technology. It's really amazing. And we welcome to the podium to Dr. Marek Griguet. So he's going to talk about new advances in steerable catheters.
Okay, thank you very much for the invitation. So I'd like to show you something about the steerable sheath. Here are my disclosures. So the first thing, why do we need a steerable sheath? We need that steerable sheath because first to avoid the misalignment, and if you can get improved access by steering, then it's easier to get to the definitely much more range of LA anatomies, and each of us had a case like that or cases similar to that or even more extreme when it's quite difficult to obtain the coaxial alignment. And when the device is misaligned, in many cases when you deploy the device, the situation is like here, that without steerable sheaths, of course, it's doable, but then it's quite difficult. And if you are doing then a TAC test or you want to just perform a contrast injections without the steerable sheaths, in many cases, you are pulling the device, but it's completely out of the coaxiality, or you are injecting a contrast, and instead of getting to the LA, that contrast is getting to the pulmonary vein. So what we have, so everything started probably with a steerable sheath from the Amplatzer, which we had in our hands, I think 3 or 4 years ago. And there was in that sheet, there was a bidirectional steering from 0 to 120. There were different stiffness of different parts of that steerable sheet. And I showed you it's somehow historical picture, but which I record in my lab. But you can appreciate how that steerable sheet was working, that in fact for me, it was just steering of the distal part of that sheet. Was it helpful? And I would say that in some cases was helpful, but in some cases, especially that when you perform a puncture not in a proper orientation, for me, with that steerable sheet, it was even more difficult to perform the case than with that steerable sheet. So anyway, you need a perfect puncture. And there are, of course, some publications showing that with usage of that steerable sheet, probably could be helpful, but as you are all aware, that steerable sheet is, as I am aware, no longer on the market. And then there is a True Steer from Watchman, and for me, that True Steer, it's a game changer. I started to use it 4 months ago, and from that time, I'm doing all my cases of LA closure, all cases, with that True Steer. Because for me, it's extremely helpful, and I don't know how to predict, or it's difficult for me to predict when I would need that. And if you switch from a traditional fixed curve sheet to that True Steer, it's helpful. So you can see how that device looks like. That in fact the range of deflection is higher, and with balls created, you are able to get to the different anatomies. And it's quite user-friendly because there is that handle, and just by turning that knob, you are able to move to the desired position. So instead of using these different types of sheets as it was in the past, you can use just that True Steer sheet. And your hands, with the usage of that, behave exactly the same as you were used in the past to the traditional sheets. So one hand on the left hand just on the knob and just to making a rotation, and the other one is just for the deployment. And what is also quite unique with that sheet, that there is, and Jens Erik mentioned about that it's possible that during deployment, and on that movie you can see that there is so-called a mid-deployment steering. So in some anatomies, you can partially open the device and then perform that steering. So if you looked again on the video which I prepared, so you can see how that steering looks like. So with that knob, you can flex or extend, and of course there are still these movements which we used so far, so anterior and posterior movement, and with that steering you can quite easily get to some difficult anatomies. Are there any data to support that? To tell the truth, not so much. I was able to find only a few presentations. Here's one of the presentation in which they showed just 12 cases in which it was not possible to perform the LA closure with traditional fixed curve, and it was possible to close the LAA with the usage of that flex steer. However, we will definitely have more scientific input from the studies for Watchman Flex Pro registry, which will be conducted in Europe. 300 of these patients will be patients which are will be treated with that flex, with that True Steer. What is also important, it's a combination, a True Steer with the Versa Cross Connect, and with that, then it's extremely easy to perform the procedure. And I will show you just one case which we did, I think, one week ago. So with the True Steer and with the Versa Cross, everything together from the beginning, you can do a puncture, and then without exchanging with that Versa Cross, you can enter to the left atrial appendage with the tip of the Versa Cross. You can enter to the appendage or be like here, quite close to the ostium of the appendage, and then when you advance the ball, and if your position is not suboptimal, of course it's not difficult, the appendage, you can steer to be coaxial, and I would say that it's quite helpful in many cases. So in such cases, and also you can appreciate that by steering you can be coaxial, and for these for the deployment of the device, whereas you can steer it in such a way that there is no, let's say, no tension on the disc. And I think that feature is quite helpful. Is it helpful in the procedure? I found one publication in which they compared the different approaches. The last one is that one with true steer and VersaCross, and not only it saves many steps of the procedures, but it's associated maybe not with the better results so far, but definitely with a reduction of the time of the whole procedure. Thank you very much.
Thank you, Marek. And thank you just to present on time. I mean, that helps a lot. I don't know if there is any comment or question.
Yeah, Marek, I would have a first question. So in how many of in your experience, in your lab, in how many patients do you need a steerable sheath to get better alignment of your device?
Yeah, I would say that it's definitely helpful in about, I would say, 20-25% of the cases. But if you use it on regular basis, as I am doing in all cases, because for me it's difficult to predict in which cases I will need it. And then exchanging from the fixed curve to true steer increase the cost. And for us in Poland, the price difference between these two types of sheaths is not a big one.
Another question there.
I have used True Steer recently for a very retroverted chicken wing, but what I found is very useful was rather than getting, I mean, coaxiality is great, but when you release it, actually, if you reverse what you did, it will slowly, you'll be able to get the device in a better position. So sometimes it's very difficult to get the coaxiality. So, but once you are in, and then when you are slowly releasing it, actually that was really helpful in addition to getting the coaxiality.
Yeah, absolutely. So that meets, let's say, deployment steering is extremely helpful, especially in the anatomies which you mentioned, that there is a chicken wing, then it's extremely helpful.
Thank you, Marek. I will also just support you. I'm also using now 100% the True Steer. I'm using it together with the VersaCross Connect. And I think that now has become very easy. Do your transeptal puncture with this system, go with a spiral-shaped wire directly into the LAA, and then advance the sheath, and you are just ready to deliver your device. So it's very easy. Yeah. And I think it's also a matter of safety, because you now can avoid changing your transeptal sheath to the delivery sheath. And every time we exchange a sheath, there is a small risk of air embolism, etc. So I think it's also a matter of safety. But and then the cost is a little bit higher, but you also have to take into consideration that you save the mechanical needle and the sheath for your mechanical transeptal system. So it's simplification and more safety, and we will get more anatomies, we will get better alignment, and in the end I am convinced that we will get better sealing as well. Still, one of the most frequent mechanisms for leaks with the flex device, it's malalignment and a tilted device, and this we can avoid this with the steerable sheet here.
Yeah, Jens, I fully agree, because we make a cost calculation, and if you, as you said, avoid this special, let's say, sheet for the puncture, needle for the puncture, stiff wire, every single one, it increased the cost of something like 150 euros in my case. So
Tom and Luis, and because we're like running out.
Okay, briefly, I just also first want to support also the value of the mid-deployment steering. I think it's the game changer for this sheet. And not only for the difficult or otherwise impossible cases, but also for the so-called easy cases, to optimize the final 5% of the alignment to go from 95% perfect to 100% perfect. Having said that, as we start doing this, we're using the device for something it was not really intended for. We're using the device to push itself against the anatomy, and we haven't seen issues, but we also have not done a lot of cases. In your experience, is there any reason for concern of using the device itself to be pushed by the sheath against the tissue wall? I'm thinking of complication risks, of course. I'm thinking of why we started using the pigtail for sheath positioning originally, because there were perforation issues.
Yeah, I would not afraid. At the beginning, especially with the Versa Cross, I was afraid to enter inside. But when I have a ball configuration, I am not afraid at all. Because with a ball configuration, I feel completely safe.
Okay, Luis.
Yeah. And when I have little experience with the Versa Cross and the True Steer, but in one case we had problems to do the transeptal puncture because it was a floppy septum, and then when we have these cases, you usually bend your Brockenburg needle, but with this sheath, I don't know if you can steer when you are doing some tension on the septum, or you only bend the dilator of the True Steer.
Yeah, with Versa Cross Connect, you can bend the dilator, and that dilator after bending keeps that curve.
But
so if I am not able to get the proper contact, I remove the dilator, bend it, and try once again.
Thank you so much, Marek. So we have to move on, but this was a great overview of the features of this device. And we are moving towards a completely different field, and artificial intelligence will be one of the drivers of future imaging. And Martin, you will give us some insights in your workflow, artificial assistant implant, from planning to execution. So you made it to the stage.
Yeah, I'm trained by now. So thank you for inviting me to giving a talk on this interesting subject. I think there probably is some other people in the room that might be even more advanced, but I just tell you my perspective, and congrats again also to the committee here for putting together such an interesting meeting. So what are the challenges with current LAAC workflow? If I think back of all the live cases that we did over the years, I think sizing is still a big issue, and missizing also leads to a number of problems that we have, including leaks and others. I'm completely new to the field of CT measurement, as we are in Germany, and we relied on TOE for such a while, so allow me to make you part of my learning curve. So when I started measuring CT, I got quite confused because it was different to the TOE measurements I did for some time. And so thinking about what we want to achieve and where to measure, actually I came up with this site where I put in something like a central axis, possibly also in the future guided by AI assistance. And then for me, the big difference, the learning curve, was that for the amulet lobe to have the correct sizing, we need to measure a little bit distal to the CX, whereas for the Watchman Flex landing zone, and I'm purposely not talking about ostium because that's a lot of confusing things. What is the ostium and where do we measure? We have this other sizing. And that we are not perfect, I think, is something that's shown in this paper from the Copenhagen group and others, where if you are really critical to your own measurements, you see that we still, even with CT standard planning, which is the left side of the curve, so what we do maybe with Symentia, as far as I understand your paper and your workflow, we have critically speaking, up to 40% at least partial leaks. And this is, I think, the first and real nice paper showing that on the right side, this is CT and simulation planning assisted by AI. You are able to improve that. We had the chance to publish a case report where we had also the option to use the FEOPS planning. It was a difficult anatomy because it was like an inferior chicken wing, and the FEOPS planning, both guiding us where to measure actually the landing zone, as well as what kind of devices would fit, helped us a lot. Because from TOE, I can tell you everybody would have picked the 28 millimeter device, which in the end, and you might have a look and judge on that paper, did not fit. I won't go into the details because this is meant to be a talk of where we are going and where AI might help us. I should add that FEOPS also has a tool to allow you to go for Watchman flex procedure planning, which so far is done with either Srimensho or this software called TruePlan, which is, I think, now distributed in the US, but it's less so well known in Europe. And you can also depict the sizing chart. Also, you can model the device in this software, but not as elegantly as done with FEOPS. I've been part of a development which I also think is quite interesting. This company aims actually to give us a virtual eye where 3D images from the echo are overlaid to the chest X-ray. And at the moment, we are testing it for pre-planning, but in the future, the aim is also to use it intraprocedurally in addition to the workflow that you have. You see the two of us there measuring different aspects of this LAA. You can look at it from many aspects. You can also model in some of the devices, particularly now this is meant for the amulet. And the nice thing is that you get a visual impression of what's doing. So turning to the intraprocedural challenges, some of this has been shown before. I think we still sometimes struggle with the correct location for the transeptal puncture, and to control the transeptal puncture you might be good, but then you slip somehow once you put in pressure. Navigating the left superior vein sometimes takes time. I'm still advocating this as a safety issue, not to go for the LAA. And then navigating the LAA sometimes is also difficult, particularly if maybe your transeptal puncture is not ideal. We got a new CAS lab beginning of last year and had the chance to implement the Echo Navigator developed by Philips now, I think, for 10, 12 years. I used an initial version back in 2013 or something and wasn't convinced, and I was quite surprised to see that this newer development we now have, once you have really done the really simple now alignment with your X-ray, for me is really helpful. Where is it helpful? Well, first, I like to use it now for transeptal puncture because you see this little red dot on the right side in the middle. That's depicted by the echo colleague to tell you exactly where you should aim for the transeptal puncture, and rather than the echo searching for where's the transeptal needle you really have on your X-ray in the right connection, it's more or less like playing on a computer now these days, and it works really well. Also, you can easily see that the wire that I put in there is above the left atrial appendage, so that is clearly in the superior vein. This is faster with this technique. Also then going for the left atrial appendage, as mentioned before, really the alignment is quite well, but I think this Echo Navigator really having an edge here over other pictures I've seen or even worked as a guest operator in other institutes, for example, for the Siemens 3D imaging. So again, you're quite fast into moving into the LAA. And I thought this to be short and more going on for discussion because we're a little bit behind time. So let me summarize. I think we all agree that an optimal LAA closure is a single device size, a single deployment, which will also always allow us to have less pericardial effusion and other risks, but also to have an optimal closure. We need to avoid device-related thrombus by optimal depth and position. I think this is a big issue of the coming years, and it will be interesting to see the new data. I'm convinced that if we all together get our experience with AI assisted device sizing, different to TAVI, I think it's interesting that in TAVI I'm quite good in navigating the inferior where the annulus is. This is different for the LAA. I think if you do have 3 operators, give a CT and measure where you land, you will have 3 different sizes. And so AI really may assist us here in this problem. And so thank you for your attention.
Thank you, Martin. Excellent talk, and just promoting the discussion. So one of my concerns, it's like, first we need to tell the intelligence, what's just the objective. So for me, it's difficult to know if it's better like a deep device with no leaks, or like a more proximal device with a minor leak. I don't know what's better. And like first we need to teach the artificial intelligence what's the optimal, because we don't agree here, and I think that's probably so. And Jordi has a question that maybe we need to go. But let me ask Martin, then you go.
Well, this level, for example, working with FEOPS or working with Articore, still leaves you a lot of decision by yourself. You're playing around. It's not that you get a fixed image and the system tells you this is the device you're going to choose. Instead, and rather than playing around yourself with other things, you really have, let's say, a virtual planning, which is much faster, much quicker. It works much better into the workflow. I mean, you don't have time for an hour to sit down before you go on the table. Huh? You want to sit down maybe 10 minutes and then have a final clue on that.
But it would be nice just to have, like something that tells you, this is the best. And
but I agree on
you
your
can
point.
get it or not, but and maybe like Jordan, in that sense, maybe it's the answer is flow dynamics. So this is the best because that's the best flow dynamics.
Actually, it was not only in flow dynamics. So first of all, Martin, thanks to be brave for talk about artificial intelligence. But second one, I've learned from you, and I would like to be a little bit provocative. For me, of all the technologies that you have presented now, only Philips use real artificial intelligence. I think that all the thing that you present is okay about pre-planning, about simulation, but not artificial intelligence. And here I agree with Xavi. I think that when you talk about artificial intelligence, it's use a lot of data to speed up processes, to be able not maybe to say, okay, this is the best one, but here you have different suggestions real time because have learned a lot of data. And I think that if we want to talk about artificial intelligence, and this is my last comment, first we need to overcome a lot of problems that, for instance, you guys are finding with the ELAACC registry. I mean, you have a lot of heterogeneous data from different hospitals that they do it differently. How we put this together to learn how we do. For me, this is my opinion on what is artificial intelligence.
I have to say that I didn't dig deep into FEOPS and how they do it, so I'm not too familiar with the technique. Also, I think it's quite useful in using it, but I have a limited experience. Articore is definitely using something that is calculating on its own the central axis, which I think is quite helpful. Because then we talk the system, okay, show me a measurement orthogonal to the central axis. I can just run through it, which is much faster than I could do on a Shemenchu because always the axis is playing. So yeah, where is it just computational work? Where is it artificial intelligence? That's a discussion I fully agree to. And so far, where is this heading? I see some of my younger colleagues to be very skeptical to move forward at all. We just do it the way we are used to because it's fine in 95% of patients. I think that's not the way forward. I think we should be the driver in this field and obviously to tell the companies that develop these things by also interacting with them, maybe the direction that we think.
Thank you so much, Martin. I mean, I think we all agree that artificial intelligence will have an impact on our future imaging approach. So we move again to a completely different field. And Sergio, to be honest, I have no idea. I have never touched this area, remote proctoring. So please tell us what can be achieved with it, what are the purposes, the objectives.
Thank you, Nina. I want to share with you our experience on remote proctoring. This experience started a couple of years ago when we won an European project in cooperation with the team, Italian company, and with the National Council of Research. And the topic of the task was to be able to demonstrate that high-tech connectivity can be helpful for in the medical use. This is the steps that usually we follow when one center wants to start with a program of LAAC closure. We start from internal training, we go ahead with several steps, and usually the pathways is concluded with the on-site proctoring. The proctor follow 4, 5, 6 cases. After that, the proctor say, okay, you're ready. It's time you fly alone. It is a very critical step for the operator because the psychological connection with the proctor is very strong, so the remote proctoring can cover this gap. Really, what is the remote proctoring on remote support? This sentence, when technology guides and expertise connect beyond distance, catch the meaning of the remote proctoring. Remote proctoring is a sharing of experience where the technology is, if important, is a tool. It's based on 3 pillars. The first is to have the availability of a device that must have some requirements, easy to install, certified for the use in the cath lab or in the operating room, completely hand-free, because the exchange of information between the proctor and the operator must be completely independent of the hands. It requires a stable connection with high-speed data transmission and, of course, a remote in proctor, expert in proctoring and expert with this technology. I want to highlight the technical characteristics of the device. In our experience, we use the smart glasses by Rod and Scone. It's important because the concept is that you see through the eyes of a partner. The technical characteristics of the smart glasses are that are completely unfree solution. You see in the in the small screen, the operator see exactly what the proctor see. The proctor can have a visualization, a complete visualization of the equipment in cath lab thanks to the mirror R, and you see the region of interest thanks to the panoramic view, and the device allows a full two-way interaction. Basically, the proctor receives 3 lines of information, one from the echo, the angiography, and from the smart glasses, that is a bidirectional exchange of information. So the proctor and the operator see exactly the same things. We conducted our experience with a controlled high-speed data transmission, but recently Italian teams and also Ericsson are able to provide a stable, professional connection. During our experiment, we were able to monitorize all the velocity of and the stability of the connection, the delay, etc. But let's go in cath lab. This is the preparation of the operator. The device does impact with the standard preparation of the operator. And in yellow, you see what the operator and the proctor see. The interaction, you see that I am drawing to the operator my instruction because in this patient was a patient with a slow-style septum, so I suggested to delay the septum with a small balloon. The operator is following my instruction. He delayed the septum, and you see that the proctor has under his control the fluoro, echo, and the environment view. Let's move to another procedural step. Now the operator is in the left superior pulmonary vein. I stop the imaging, and okay, you are here. You are in the pulmonary vein. Your appendage is exactly in this position, so you have pulled back the system, a counterclockwise rotation, and you will be in front of the LAA. And this is the phase when the operator is in front of the LAA, okay? This is the LAA, okay? This is your line of advancement of the device. Follow the red line, okay? There are a lot of tools. This is one of the most frequent used. And now another intraprocedural step is to define the landing zone. Okay, your landing zone is here. Take care of my line, take care of the marker on the catheter, and this is the line that you have to follow for a correct alignment of the device. And also the interaction with the KIP is easy. This is the interaction with the specialist on the basis of the measurements during the planning and during the intraprocedural phase. We discussed what is the optimal device. It's important that the communication, the bidirectional communication, include also the voice, the detailed information, the exchange of for the correct device. And finally, I want to show you the zoom effect. This is the very critical step of the procedure when the operator has to detach the device. Okay, I explained the rate of compression is fine. You can go ahead. My experience and my final conclusion are that the remote proctoring is an alternative, but is not an alternative, but is a natural extension of a current educational strategy. Our committee should be open-minded to new technology and new perspective to education and proctoring, because it provides a real-time support with a more accessible proctor and expert guidance, improved training, making it more flexible and collaborative, and it facilitates a gradual detachment from the proctor. And another very important aspect that we could think to a network where the proctor on demand support the colleagues if they have a complication or if they have to manage very complex cases. Thank you for your attention.
Sergio, a fascinating new tool. So when I watched your image, which is real time on the right upper left, on the right upper right panel, if I would have to watch that, I would feel a little bit of dizziness. And if you have an operator, so I just talked to Javi, and he said he's moving his head a lot during the interventions. Does this has an impact on the quality of what you see and what you have to command?
That was a problem with the previous version of the smart glasses. Now they are equipped with a gyroscopic stabilizer, so the distance effect is not so strong, but we have to explain to the operator to avoid to move too fast, to stable view. And it's important that when you speak with the operator, okay, let me see your hand, let me see the device. This is especially important during the device preparation.
Yeah. And
Sergio, very nice talk. A question. I proctored a few times remotely but without the features which you show. So these lines which you draw, the operators are seeing these lines and your drawings on their main screen or on some small screen? How it works?
No. When you draw, the operator see immediately what you are doing in the smart glasses. So the smart glasses, yes, reflect exactly what the proctor is doing, and the proctor see what the operator is seeing. So when you want to exchange information, you stop the view, and you can draw or you can write. Usually, I prefer to use the pen, the pencil for drawing the different color because it's more intuitive.
Yeah, but anyway, your suggestion is that first the center is doing cases with proctor on site, and then for how many cases, in your opinion, should be done with proctors on site before moving to that remote proctoring?
I think that what we are doing currently, so the proctor on site will remain because the direct contact with the team is important. But one very critical step is when you say, okay, you are ready. The next case is your case. And this is a very critical step where the operator is ready, but the psychological link with the proctor is strong.
Yeah, I completely agree because they need. Yeah, Philip, sorry. No, go.
Two short questions. First, the audio connection is sometimes difficult, especially when you're far. So how much you need the audio connection when you have the glasses and all this excellent network and system?
It's a technical problem. The smart glasses, the tools for connecting the echo and the fluoro are wireless. So the main problem could be, I had one stupid problem with my administration is to send outside of my center data regarding a patient. But it's exactly the same problem we had when you do a live case. It's exactly the same situation. The second problem is to have a stable bandwidth. Recently, Italian team guaranteed that they have some professional band that you can buy for 2, 3, 4 hours. It's not particularly expensive. And because the problem is the stability of the connection and the delay between the transmission and the feedback. Basically, with our dedicated band, but that was an experimental band managed by Ericsson, the delay was basically 0, but with the commercial band is close to 0.
Okay, I think that because you had like some very nice questions, and we're running out of time, but I will do it the manual way. You know, just I would like to ask you and raise your hands. So who's in favor of remote proctoring, not for the first round of cases, but maybe for a second or third round of cases?
Xavi, it's important to highlight that remote proctoring doesn't replace the proctoring because
exactly.
Yes, it's an integration, is complementary to the yes.
Not replacement for a second stage.
Yeah, exactly.
So I like it.
And also important to create a network for a second opinion.
Yeah, exactly.
For complex cases.
It's for reassuring the operator. Yeah, exactly. Yeah. So let's, who likes?
No, they want to ask.
And who doesn't like?
Xavi, you want to vote? Or?
No, because we're super late, so we need to move on. So Sergio, you stay because we go to the next session, and you are moderator in the next.
Sergio, I just hand the micro over, and I think it might be something good for the regions in the world where proctoring access is less favorable.